This week's discussion is on depression in adolescents and children. The signs and symptoms of depression in adolescents and children must include at least five of the following symptoms in a 2-week period, and it must include at least one of the first 2 symptoms: depressed, irritable mood, diminished interest or loss of pleasure in almost all activities, sleep disturbances, whether it's unable to sleep or sleeping too much, weight change and appetite disturbances, failure to achieve expected weight gain, and decreased concentration and indecisiveness. Suicidal ideation or thoughts of death, preoccupation with death, psychomotor agitation or retardation, and fatigue or loss of energy or complaints of a heavy feeling in legs and arms, and feelings of worthlessness or inappropriate guilt. The symptoms must cause a significant distress or impairment of important functioning and must not be attributed to direct action of substances or any other medical or psychiatric conditions. You must also always clear medically to rule out any kind of organic etiologies that would have been causing these symptoms, such things as infection or reactions to medications, endocrine disorders, tumors, or any kind of neurological disorders. The pathophysiology of the depression, it is believed that there are several areas of the brain that are involved in mood function. Sleep, appetite, and memory are common disturbances in depression, and they are considered to involve our limbic system. All components normally receive signals from neurons and secrete serotonin or norepinephrine, or from neurons of both types. Reductions in activities of circuits using serotonin and norepinephrine may contribute to the depression. PET scanning of some depressed individuals have found areas of the prefrontal cortex with abnormally diminished activity. The prefrontal cortex is related to our emotional responses. Unfortunately, PET scanning is problematic in pediatric patients because of the amount of radiation that it requires. MRIs in depressed youths have found smaller ratios of frontal lobe volume to total cerebral volume as compared to the ventricular volume. This suggests that cerebral volumes for the frontal lobe may play a big part in the development of the early onset of depression. Medications that are most commonly used in pediatric and adolescent cases. The antidepressant SSRIs are beginning to be used more in pediatrics. The most common one used is the Prozac, and it selectively inhibits the presynaptic serotonin reuptake with minimum or no effect on the norepinephrine or the dopamine, and has been best suited agent for pediatric depression. Paxil is a potent selective inhibitor of serotonin reuptake with a weak effect on the norepinephrine and the dopamine reuptake. And Zoloft inhibits the presynaptic serotonin reuptake, and it is approved by FDA to treat OCD in children, but it has been used off-label to treat depression in pediatrics. Celexa enhances the serotonin activity, but it is not FDA approved for children. However, there have been clinical trials that have shown Celexa to be effective in treating moderate to severe major depression in pediatrics. TCAs, or tricyclic antidepressants, block the reuptake of neurotransmitters, serotonin, and norepinephrine in the nerve terminals. TCAs are not recommended for the first line of treatment in pediatrics. If they are used as when other antidepressants don't work, and they are used in pediatrics, the most common ones are tofranil, Pamelor, norepinephrine, and amitriptyline. And the thing about tricyclic antidepressants is they should be initiated at low doses to minimize the adverse effects on adolescents, as adolescents metabolize these medications differently from adults, and they do have a lot of symptoms and adverse reactions that need to be monitored closely.